Good morning, everyone. And thanks to the ADA, I'm up here. Otherwise, they'd have retired me a long time ago. But not without a battle. I have way too much fun being up here. I don't know if I should be admitting that. Oh well. So it's almost 9 o'clock in the morning. You made it through to the second day. And I didn't see anybody cut and run when I got up here, so I guess I didn't make you too crazy, huh? Okay, so get your coffee, hang on to your pens. A lot of the changes in this section are down to a significant single or pair of words that are going to make a very significant impact on how you're going to go about handling one of your very favorite things. Med-Rec, right? You're not looking like it's your favorite thing. Come on. I can hear all of your nurses already going, They're coming back. They're going to talk about it yet again. Okay. Now, if I can make this thing work, we're all set. There we go. We're going to start once again by saying that we need to look at the terminology. As Anne reminded you, when I say how we're going to code the question, we're not talking about ICD-10. And that's important because your staff will be confused by that. We're talking about how we respond to or score the OASIS assessment item. So make sure that you do share that distinction with them. Our topic this morning is going to be the process of drug regimen review, how this is conducted, and how you use follow-up for the issues that you identify. So what exactly does this mean? Drug regimen review has been adopted as a patient assessment-based, cross-setting measure as part of the IMPACT Act. This measure is looking at whether or not, as providers, we are taking responsibility and acting on, are responsive to potential or actual clinically significant medication issues. Those are the key words. We're going to be emphasizing those words over and over during our time together. Clinically significant medication issues, when such issues are identified. And this measure ultimately will be applied all across the post-acute settings. So what does this actually mean? How do you describe this particular measure? This is going to give you a percentage of patient care episodes. Remember how you define a patient care episode in which a drug regimen review was conducted at the time of start of care or resumption of care. And timely follow-up, very important, timely follow-up with a physician occurred each time potential clinically significant medication issues were identified throughout that care episode. There were key words in there, and I want to be sure, even though it's early in the morning, that we have picked up on all of those key words. We conducted that review at Sock and Rock. We had timely follow-up with physician contact. Each time we identified a potentially clinically significant issue throughout the care episode. There's a great deal involved in getting all of those pieces met. Now we're going to talk a little bit about math. For those who know me well, they're all waiting to see if I'm going to run screaming off the stage. Because most people know that I don't do math very well. We're looking at defining the numerator and the denominator here. The numerator is the number of episodes, and I'm going to read this because the mathematical definition matters. The number of episodes in the denominator where the medical record contains documentation of a drug regimen review conducted at start of care or resumption of care with all potentially clinically significant medication issues identified during the course of care and followed up with a physician or physician designee. That's your numerator. Your denominator is the number of patient care episodes with a discharge, transfer, or death at home assessment during the reporting period. Because it's not a contained episode until you have that discharge or transfer or death at home. So those are the definitions. What doesn't get included there? What's excluded from the denominator? There are no exclusions. Risk adjustment doesn't apply here. This is not a risk-adjusted or stratified measure. It's very straightforward based on those definitions. So where does the data come from? There are 3 specific OASIS C2 items that are going to come into this measure. 2001, the actual drug regimen review item. 2003, the medication follow-up item. And 2005, the intervention. So notice that there's a distinction between the follow-up, which is the contact between your clinician and the physician or physician designee, and the intervention, which is, did they do what they were instructed to do? Did they follow up and complete the new order, if in fact there was one? If data is missing in any of these 3 items that are part of calculating the numerator, the upper number, the patient is not included in the numerator count. The patient will continue to be included in the denominator, assuming that all denominator criteria for that patient have been met. So what is that now going to do to your percentage result? That's right. So the first step is to calculate the denominator. We count the number of episodes with a discharge, transfer, or death at home assessment. That's relatively straightforward. The next step is you're going to calculate the numerator. We count the total number of episodes where we have that documentation that the drug regimen review was conducted at the start of care, resumption of care, and at discharge. But look at all that's involved in that discharge review. We're talking about a look back. You need to go back through the episode. You need to look back to start of care or resumption of care. So if your episode spanned multiple recerts, you cannot only go back to the most recent recertification or follow-up OASIS prior to discharge. This is clearly stating that your look back goes all the way back to start of care and resumption of care. And it must include all potential clinically significant medication issues that have been identified during the course of care and were followed up by contact to the physician or physician designee. Now here comes your time frame, by midnight of the next calendar day. Because after all, aren't we 24/7? So the third step is to actually do the math. You're going to divide the numerator count by the denominator count. You're going to get an observed score. In other words, you've divided step 2 by step 1. And that's enough math for the morning, right? We're done with this now. After all, you're talking to someone who would rather pay than balance her own checkbook. So let's begin actually collecting some data here. We're going to begin looking at item M2001, the drug regimen review. We're going to answer this question. Did a complete drug regimen review identify any potentially clinically significant medication issues? So let's take a look at exactly what that says. I apologize, I keep stepping back from the microphone. We have a comparison here of the old item in OASIS C1 that's going away, that was numbered 2000, and the new one, 2001. You can see that the previous item was worded much longer. Does a complete drug regimen review indicate potentially clinically significant medication issues? And then it lists them all. Adverse drug reactions, ineffective drug therapy, significant side effects, et cetera, et cetera, et cetera. In OASIS C2, 2001, simply says, did a complete drug regimen review identify potentially clinically significant medication issues? And it assumes you know what that list is. So here's what the question looks like on the page, giving you your answer choices. Does a complete drug regimen review indicate potential clinically significant medication issues? This is the old one. It gave you a 0 option here that said not assessed or reviewed. Now, is that something that you would want your clinicians to be doing? Thank you. I feel much better. Number 1 said no problems were found during that review. Number 2 said that, well, yes, there were some problems, and the not applicable option was that the patient was not taking any medications at all. This is how it was. How it will be no longer gives them the option of, well, I didn't go there. I didn't do any assessment or review of the medications. It now simply says, did a complete drug regimen review identify the potentially clinically significant medication issues? Giving you 3 choices. No, there were no issues. Yes, there were issues found, or not applicable, the patient is not taking any medications. This does not mean the patient is not taking any medications because they choose not to take them. The drug regimen review is, here's the list of medications. Are there issues with these medications? And if you have a patient with a list of medications who is not taking their medications, you have an issue. And so you would answer that question, 1, yes. So let's look at the changes. When you had C1 and C2 side by side in front of you on that slide, here are the examples that have been taken out. Not assessed, not reviewed is no longer a response option. There are wording changes. In other words, problems were changed to issues. The NA response is now coded as 9 NA. What is the intent behind this? What is it that we are being asked to do? We are being asked to identify whether or not the review of the medications indicated, and here it comes again, we're going to keep saying this over and over, potential clinically significant medication issues. With a reminder that we look at this at start of care when it's all new, and resumption of care, because a resumption very often is accompanied by changes. What does it mean to say that there's an interaction with a medication? We need to understand what some of these potential clinically significant issues might be. An interaction is when 2 substances react together. Prescription medications are not the only things that can be involved here. It could be, yes, another medication. It could also be a nutritional supplement, like these herbal supplements. You go into any drugstore and pharmacy and you're going to find aisles of them. And so when you ask your patient as part of that, remember yesterday, that health history, that complete comprehensive assessment, tell me about the medication that you're taking. And they produce the infamous home health brown paper bag or the shoebox that comes out from under the bed or the couch. Believe me, I've seen it all. Shopping bags full. Herbal substances, foods. How many times have you seen a medication with an instruction should not be taken with grapefruit, should not be taken with citrus juices? Does your patient know what that means? I don't think so. Or many times it has to do with the components that are used in diagnostic studies. You need to know these things or know where to find them. The interactions between them can alter how the medications are absorbed, how they act in the body, how they affect the patient's metabolism. You need to understand that it's going to decrease potentially how that medication works with the patient and increase the potential for more adverse consequences. What's an adverse drug reaction? Think about that. If you had a new nurse that you were orienting, they can come to you from the facility environment and really struggle with understanding the difference between an interaction, an ADR, an adverse drug reaction. It's the secondary effect of a medication that is usually undesirable and different from the therapeutic effect of the medication that was intended. It can be any response to a medication that is noxious, unpleasant, negative, unintended, was not the purpose for which it was ordered, and can occur in doses that are given for prophylaxis, for diagnostic purposes, or for actual treatment. I can't stress how important this is. And it has absolutely nothing to do with the background or education of the patient. I can give you a very, very good example. Fortunately, a long time ago, my daughter was diagnosed with Hodgkin's disease. She was going to chemo, and they tended to schedule the patients in age groups because they bonded and seemed to do better. So she was sitting next to the 20-year-old next to her, and they were chatting about what they were throwing up every day. And the young lady sitting next to her said, "Oh, well, you should go and see my friend. She's an herbalist. And she gave me these herbal supplements, and they're really making a big difference." And so my daughter, not knowing any better, went home and took them, bought some, started taking them. And I got a frantic call. Doctor's very concerned. My blood work isn't as good. And I said, "So what's different?" "Oh, I don't know, but I feel better because I've been taking these herbal supplements. And 3,000 miles away, I thought I'd go through the phone." So we talked to the physician, who then personally spoke to every single patient in chemo and said, "Bring in those herbal supplements. We need to talk about this." Because specifically the ones that these young people were taking to feel better were interfering with the therapeutic effect of their chemo. And they had no way of knowing it, and they assumed it was herbal over the counter, must be safe. They didn't need to tell the doctor. So you need to be asking, because think about what kind of an interaction or adverse effect could be happening right in front of you, and you're not going to know if you don't ask the questions the right way. So what's a side effect? A side effect is something that's expected, well-known or documented reaction from a medication that is usually not going to be of significant harm. It's occurring with a predictable frequency, and it may or may not really be an adverse consequence. This term can be used interchangeably with an adverse drug effect, These side effects fall into one of 5 of the ADR categories. They're listed here. You have side effects, you have hypersensitivity, you have idiosyncratic response. How many times have you seen a physician order Haldol and something that was supposed to calm down and relax your patient turns your 85-year-old into a little fighting tiger who could deck you if you get too close? That's a paradoxical effect. Trust me, my mother decked an intern in ICU on 1 dose. You can have a toxic reaction, or you can have a true adverse event. So, what kind of activities are included in actually performing this drug regimen review? We need to complete a medication reconciliation. We need to review every medication that your patient is currently using. The purpose being to identify and hopefully prevent any potential, again, clinically significant medication issues. This includes everything that was prescribed for your patient, everything they may be taking over the counter. It includes TPN. It includes the herbal and vitamin and every other kind of supplement that your patient can think of. It includes every possible route. So that topical over-the-counter that they picked up in the drugstore for the rash they forgot to tell you about may very well be 10% cortisone. And what is that going to do to your diabetic? So think about that. It's every possible route: oral, topical, inhalants, a pump, an injection, an intravenous, or an enteral tube. Many of you have patients that are on total nutrition with a peg of some kind, a gastric tube. You need to include in your consideration everything that goes into that tube as well. What is a potential clinically significant medication issue? I was going to count to see how many times that phrase appears in this presentation. I got up to about 15 and I quit. And yes, I'm going to keep right on saying it. It's an issue in the care provider's clinical judgment that requires you to notify the physician or the physician designee by midnight of the next calendar day at the latest. It doesn't mean, well, I can always do that tomorrow morning. If this is a significant clinical issue, you need to have an established agency standard of practice for how they are going to respond and what the time frames are going to be. In addition to these potential issues, you need to also be identifying existing clinically significant medication issues that in your clinician's judgment requires that they speak directly to the physician or physician designee within that time frame. These potential or actual medication issues could include, as some examples, an adverse reaction like a rash, an ineffective therapy, an analgesic that's just not giving them pain control, side effects, potential bleeding issues from anticoagulant therapy, drug interactions themselves, a serious drug-to-drug, drug-food, or drug-disease interaction. So remember these 4, because these are the things you need to stress. When you go back and take these presentations and use them to train your staff, think about how you want to present these and what examples you can draw from your own patient records in order to teach this material. These are also included, but not limited, because I'm sure there are a million other examples I haven't thought of. What about duplicate therapies? and the patient who's taking both low pressor and metoprolol. Because I was taking the low pressor before, but when I came home from the hospital, I had this script, so I filled it and I took both of them. And I wonder if that's why I fell down every time I got up off the couch. So duplicate therapy. Omissions. Perhaps they have 4 prescriptions in their hand as they were discharged from the hospital or from their emergency room observation, and they haven't filled them. They're not there in the brown bag or the shoebox. They're not there in the med box. The scripts are still here on paper. What about dosage errors? Doing medication review and reconciliation does mean taking a look at that med box that some family member or the patient themselves may have pre-poured. Make sure that they are actually pouring or taking what is written on the script. Check the orders against the bottles. And then our favorite friend, right? Non-adherence. This is the new way we're supposed to say non-compliant, as in, no, I don't want to take those pills. Regardless of whether it's on purpose or accidental, it's still an issue. The clinician who is completing the SOC-ROC OASIS tool needs to verify and enter the information on the OASIS tool themselves, even if portions of the review are delegated to other agency staff. Okay, this can be a difficult concept. Collaboration with another member of your staff. Collaboration with a pharmacist to get assistance in understanding whether or not any of these interactions, adverse drug events, potential problems exist. Doing that may require your clinician to collaborate with another person on the team, as long as they are the person who enters, codes the answers. The collaboration is not an issue. So read the slide carefully. Collaboration, in which the assessing clinician evaluates the patient's status and another clinician assists with the review of the medication list, does not violate the requirement that the assessment is the responsibility of and must ultimately be completed by one clinician. So hold that thought. Collaboration is allowed. No one is going to say, you were the one assigned, you were the only person who's allowed to think about whether or not there are problems with this list of medications. They can collaborate. And given the complexity and the speed with which new medications appear, think about how you're going to meet that need. Agency policy and practice will determine this process, the collaboration process, and how it is documented. The Moon 90 date, the date the assessment is completed, would be the date when the 2 clinicians collaborated and the one responsible for completing the assessment tool coded the answer and completed the assessment. So I want to be sure that everyone understands how you would go about doing the collaboration and ensuring that this happened. And hold on to the thought, agency, policy, and practice will determine how you go about doing this. So 2001, the specific instructions for how to code this. We are using just these 3 choices. Remember, we eliminated the option to say I didn't go there, not assessed, not reported. So you have 3 choices. The 0, no, there were no issues found. The 1, yes, issues were found. And 9, not 2, 9, not applicable. The patient is not taking any medications. Based on the clinical judgment during the review, the clinician will decide in the situations here that the response should be entered. The patient's list of medications from the inpatient discharge instructions matches the medications that the patient is showing the clinician during the start or resumption of care visit. The assessment indicates that the diagnoses and the symptoms that match the medications are adequately controlled based on the assessment within the clinician's scope of practice. There are a lot of external factors that come into play here. Medication drug regimen, a review, clearly, as I said yesterday when we were speaking about the diagnoses themselves, this is the other side of that same review. It's imperative. You need to look at all of the medications, look at the diagnoses, consider the symptoms that came about that are in your awareness from your comprehensive health assessment, from your interview, and make sure that you can literally draw the dotted lines back and forth. Because if you're missing something, if you have a medication or a symptom that doesn't have a mate, you have a diagnosis listed as active that doesn't have a mate in the medications, then you have an issue that you have found. So based on your clinical judgment, when you're doing this review, you can say there were no issues if the patient has all the medications they were ordered, they have a plan and the capability for taking their medication safely at the right time and in the right way. The patient has no evidence of signs or symptoms that could be adverse reactions from those medications. Again, based on your clinical judgment during that review and the questions that you're asking in your health history, you might say, there is a potentially clinically significant issue, and I need to answer yes. If the patient's list of medications does not match the medications that they have and that they intend to take, and if the assessment identifies that there are diagnoses or symptoms for which the patient is taking medications that are not adequately controlled, again, as best as the clinician can assess within their scope of practice, then you would in fact need to say, yes, there are issues here. Some additional examples. The patient is confused about understanding when and how to take their medications. This presents a high risk for errors. The patient doesn't have all the medications or indicates to you right up front, I'm not going to be taking these. I didn't fill the prescription because I couldn't afford it. I had to pay the rent. I had to pay the light bill. And this prescription is $300 for 6 weeks, and I can't do both. Perhaps they have no access. They handed me these papers, but there's nobody to go get them, and my drugstore doesn't deliver. I don't like those. In my religion, in my culture, in my family, we don't take these. They may have other issues. Look at the size of these pills. I can't swallow them. We laugh, but it's true. The patient may have already, from a first dose, evidence of signs or symptoms that are an adverse reaction to one or more of these medications. So that based on that, you're going to be again saying, yes, there are issues. If they are taking multiple non-prescription medications, over-the-counters, herbal remedies, especially the kind that they get from the next-door neighbor or the lady down the hall, you don't even know what's in those. They could be interacting with prescribed medications in a negative fashion. They may have a complex medication plan with medications from multiple physicians, from multiple pharmacies, so that there is no actual reconciliation being done from one physician to the next, from one pharmacy to the next. That creates a very high risk for a drug interaction to occur. Any one of these could reach a level of clinical significance that warrants contacting the physician or his or her designee, and bear in mind the time frame, by midnight of the next calendar day. If you have a circumstance that doesn't require immediate attention, something that the patient has but says they're not planning to use or they haven't used it in a while, especially if it's herbal, over-the-counter, a lotion or some type of ointment, but they're not actively using it, that would not be a potential or actual clinical significant medication issue because they're not actively doing it at this time. You might still want to discuss it so that you could get back to the patient and say, don't start again either. But you don't need to say, yes, I have an issue in that situation. Can we use the dash in 2001? The dash is a valid response for this item. It indicates that no information was available or the item could not be assessed. This will occur when the patient is unexpectedly transferred. Remember, for an assessment, you have a 5-day window and ROC has 48 hours. If the patient is unexpectedly transferred back to the hospital or an inpatient setting, if they are discharged or they die inside of that window, the assessment can't be completed. But you should truly complete the transfer and discharge assessment to the best of your ability and use the dash on very rare occasions. You really need to give it your very best effort to get all of that reconciliation done, to reach out and make the contact, and to document what you've done inside the time frame. Patient assessment, specifically medication reconciliation, the drug regimen review, is a condition level requirement, 484.55. There's no escaping this one. We need to be doing this, and we need to be doing it completely and effectively. It needs to be in the clinical record. It needs to be in communication notes. You need to have an accurate medication list. And if you have done a discussion with another agency staff member as part of the process of completing the regimen review, this must be documented. Remember, on an earlier slide, the collaboration must take place in accordance with agency standards, policy, and procedure. If you don't have one, you need to consider that statement, agency, policy, and procedure. Medication issues are constantly evolving. New medications come out almost daily. It's very important to refer to a current authoritative source. You need a validated reference tool in order to do accurate, detailed medication reconciliation and a regimen review. Otherwise, you're not going to have the most current information about recommended dosing, how to monitor, what adverse effects you might be looking for. So consider, what do you currently have available to your staff with which to do a validated resource medication regimen review? The physician's drug reference, other clinical handbooks, or software may be of use to you, as long as they provide the information that you need. Appropriate dosing, the side effects, drug reactions, and that they can give you risk level warnings. Any Q&As that you have, any questions you have may be answered in the CMS Q&As, which are on the web page. There are many different kinds of resources online, and these can all be found in Chapter 5 of the manual. So let's practice a little. Is everybody still awake out there? Did I put you to sleep yet? No? You sure now? Okay. Because I'm going to be having my clicker. Has everybody got theirs? Who's the designated clicking person for your table? Make sure you've got it there, because we're going to go through these questions now. No sleeping. I'll be out there with my little wire basket collecting those cell phones. No checking your emails. We've got to pay attention here. Okay. During a comprehensive assessment visit, the physical therapist reviews all the patient's medications and identifies no problems, except, I hate that except the patient's newly prescribed pain medication is not in the home. The daughter states, we are only going to pick it up from the pharmacy if the pain got bad enough. The physical therapist emphasizes the need to comply with the physician's instructions with this new medication. Prior to the physical therapist leaving the home, the daughter went to the drugstore and returned with the medication. How often do you think that happens? She really goes out and gets it? So how are you going to respond to 2001? Are you going to enter number 1? Are you going to say 0, no issues? Number 1, yes, there was an issue? What do you think? I hear a lot of conversation. Was there an issue or not? Was it resolved or not? The correct answer is that no issues were found during the review. And the reason is because the patient had the script. It did not require contacting the physician because the daughter went out, got the script, and brought it back before the clinician left the home. So let's try that again. This time, during the comprehensive assessment visit, the RN reviews all of the patient's medications and identifies that the medications have been ordered by several different physicians. These medications include eye drops and topical ointments. The patient also says she takes several herbal supplements, but she doesn't know if her physician is aware of them. The RN determines this to be a potential clinically significant medication issue. She discusses with the patient the importance of consulting with her physician before taking any over-the-counter supplements or medications. So now we have to fill out the answer. Is it a 0? There were no issues? Is it, yes, there were issues? Oh, look at that. Everybody thinks there were issues. Are we all done? Everybody pushed their button there? Okay. And look at that. We were 100% right. I guess that means everybody's awake. Good. And you got another half hour before coffee, so hang in there. Okay. The correct answer is, in fact, that issues were found. The nurse uses her clinical judgment to determine that a potentially significant issue exists. The patient has medications ordered from more than one physician, increasing the risk of drug interactions. This is a very significant issue. Unless all those different clinical practices are on the same electronic record system and they actually communicate with one another, the risk of physician 1 ordering something that physician 2 is going to have an interaction problem with is very high. And this is something we need to be looking at so that we can address it. On top of that, our patient has told us that they're taking herbal supplements that could interact with those prescriptions. So we have two issues that are complicating this and making this a significant clinical issue. One more time. Got your clicker? As part of the assessment visit, the nurse is conducting the drug regimen review. He finds the patient's list of medications from the inpatient facility matches what the patient has. He sees that there are no clinically significant medication issues at this time. The patient says she doesn't take any over-the-counter medications or herbal medications. She's able to take all of her medications independently. So, how would you answer this one? No issues? Yes, there was an issue? Or patient's not taking any medications? What do you think? So enter your answer. Oh, look at that. Everybody is awake. I thought maybe you were just pushing whatever was closest. And son of a gun, you're right. There were no issues. The critical questions were asked and answered. The review was done. Everything's present and accounted for. There were no interactions, and the patient was able to demonstrate their ability to take the medications independently. That's the way it's supposed to be done. So no issues were found, and the nurse used clinical judgment to determine that there were no significant possibility for, that she needed to act and react to something. Let's move on. Let's look at the next one, 2003, medication follow-up. Now we're talking about a different kind of contact. Did the agency contact the physician or the physician designee by midnight of the next calendar day and complete the prescribed or recommended actions in response to that identified potential clinically significant medication issue? Think about that sentence. Can you identify what are the significant phrases in there that are different? Little caffeine jolt, excuse me. Let's compare C1 against C2. In C1, 2002, was the physician or physician designee contacted within 1 calendar day to resolve clinically significant medication issues, including medication reconciliation? Okay, that's pretty straightforward, you would think. 1 calendar day. In OASIS C2, the question has been reworded, and look at the differences here. Did the agency contact a physician or physician designee by midnight of the next calendar day and complete the recommended or prescribed actions in response to the significant medication issue? Those are the pieces that we need to remember. This is what it looks like on the page. Here's the C1. You see how much shorter it is, and it has the no and the yes only. When we look at C2, we have now the additional component. The time frame is different, by midnight of the next calendar day, and did they complete the actions that were prescribed or recommended? Those are the significant differences. So remember those when you are teaching, and consider actually putting them up side by side, just as we've done here, so that you can draw the comparisons and help your staff to see the differences. Within 1 calendar day has been clarified to say by midnight of the next calendar day. Very often, your clinicians are busy all day. It's the end of the business day by the time they're making these calls, And I don't know about you, but I've seen physicians returning calls directly to patients, to clinicians' cell phones at 6, 7, 8 o'clock at night. So this is recognizing that we are not an 8 to 4 operation. Any issue that is labeled potential clinically significant medication issue, all issues fall under this umbrella. And the physician contact and completion of the recommended actions. It's not or. The phrase here says, physician contact and completion of the prescribed or recommended actions are both required. So what's the intent? These changes very easily could be dismissed as semantics. What's the significance of a word or two here and there? There is an important significance, and let's look at the rationale and the intent behind these changes. First, we have to identify if we found a potential clinically significant issue as part of the medication review, was this addressed with the physician or physician designee by midnight of the next calendar day after it was identified? It's giving you a clear and specific time frame. One calendar day was too generic. A complete drug regimen review with identification of the issues are medication management best practices in healthcare settings. Best practices are not necessarily required by the conditions of participation. However, as you've seen on the slides themselves, it does say, according to agency standard, policy, and procedure. So what is in your policy and procedure? And how are you validating, supporting, and verifying that? When are we going to be answering this question? We are still answering this question at the same 2 time points: start of care and resumption of care. Let's talk a little bit about contact with the physician. We all know this is probably one of the most difficult parts of being in home health. How do you get a hold of the physician or the physician designee? You've got a problem. I've got this med rec, I did this, and I found this problem. This patient is on clopidogrel, they're on Plavix, they're taking aspirin. Oh my God, they're covered in bruises. I need to talk to the doctor. Well, he's really busy today, can't come to the phone. So how are we communicating? Telephone, voicemail, electronic means, fax, any other means that appropriately conveys the message of the patient's status that you can document in your record. The communication can be done directly to the physician or the physician designee, or indirectly through the physician's office staff on behalf of the physician. But note the last question there, the last piece. In accordance with the legal scope of practice. Please, when you go back, look up the legal scope of practice in your state. Do you have implications that you need to be aware of in who can speak with whom, who can leave a message, what route or means you can use? You need to verify what any limitations that might exist in your own state. Let's take a look at the item itself again as it appears on the form. You have 2 choices, the yes or the no. You're going to check off the box, either yes or no, based upon whether or not you've been able to make that contact. To say yes, the two-way conversation, and completion of the actions must have occurred by midnight of the next calendar day. after the potentially clinically significant issue was identified. If the physician or the physician designee recommends an action that will take longer than the allowed time to complete, you can enter yes, as long as by midnight of the next calendar day, you have taken whatever actions are possible to comply with what you were instructed to do. Here are some examples. The physician's instruction to the agency staff is to continue to monitor the issue over the weekend and call in if a problem persists. The physician instructs the patient directly to address this concern with his primary care physician on the visit that is scheduled to occur in 2 days. The actual type of actions recommended have to be considered in order to determine whether or not you have taken whatever action steps are possible by midnight of the next calendar day. You always have to look at what is it that the physician has told you to do, what instructions are being given for the patient, and what steps can you take and complete within the time frame that is required. If the physician or physician designee gives you no new orders in response to the issue you've brought to them, you enter yes, indicating that they were contacted and the actions were completed, because they didn't ask you to do anything additional or specific. When multiple issues are identified, all must be completed. They have to be communicated to the physician or his designee, and all recommended or ordered actions must be completed by midnight of the next day in order to say yes. If 2 separate medication issues are identified, both of them need to be communicated inside the time frame. The physician or designee must provide a recommended action for each of those issues, and you can enter yes if both of the actions are completed by midnight of the next day. If both of the actions could have been addressed, but only one was, then you need to say no. This is all the issues were identified, all the actions were taken, or no, we didn't get them all done, or they didn't respond to all of them. You don't get partial credit. If a potentially significant issue was identified, the clinician reached out to the physician and/or his designee, but did not receive any communication back. And of course, this never happens, right? I saw those eyebrows go up. The answer has to be no, because you're falling outside of the time frame. If agency staff, other than the clinician responsible for completing the OASIS, have contacted the physician designee to follow up on those issues, this information needs to be communicated back to the clinician so that the appropriate response can be done. In other words, we're talking about that collaboration issue again. And if your nurse has several visits and she's identified this issue, she's called into the office and said, supervisor, I need your help here. Here's the issue. Can you follow up for me? The supervisor can certainly do that, place the call, get the orders, but then the loop is not closed until they reach back out to the clinician, communicate the new orders, and the clinician completes them by midnight of the next calendar day. That way, you are now able to answer the question appropriately. I can't stress the second bullet enough. This collaboration does not violate the requirement that comprehensive assessment is the responsibility and must ultimately be completed by one clinician. But you are able to collaborate and work together. Are you allowed to use a dash in 2003? 2003 does allow for the dash to be a valid response. It again says no information was available or the item could not be assessed. This is an and/or. Again, the circumstances are the same each time. The patient is unexpectedly transferred, discharged, or dies. Before you can complete the assessment inside the 5-day or 48-hour time frame. But you really, really need to put the effort into trying to complete the transfer discharge assessment as completely as possible. And remember, the dash should be a very rare occurrence. Where are you going to find or put the documentation? That you you identified the issue, contacted the physician, obtained instruction, and completed the actions within the required time frame. Your clinical record, communication notes, on the plan of care, in the medication list. You can document any discussions or collaboration, care coordination that you have done with other agency staff as part of the process of completing and documenting this medication drug regimen review. In today's world, I can't imagine trying to deal with the many different and new medications that are coming out without having access to a pharmacist. You truly want to think about what you're doing for practice and for verifying and validating the resources that you use, because that is going to be critical for patient safety. So let's think about some scenarios. Who's got the clickers? I want to see them. Let's see those clickers. Are we all ready? Okay, I don't want anybody sleeping on me now. If I'm up, you're up. 2003. Here's our first situation. During the start of care comprehensive assessment visit, the nurse completes her drug review. She identifies that the patient is taking 2 antihypertensives, one that was newly prescribed during the recent hospital stay, and another that she was taking prior to her hospitalization. Now, is there anybody in this room that hasn't seen that situation? I think not. During the home visit, the nurse contacts the physician's office, leaves a message with the office staff, the designee, providing notification of the potential duplication drug therapy and requesting clarification. The next day, the nurse returns to the home to complete the comprehensive assessment. Start of care, 5 days. The next day she returns and again contacts the physician from the patient's home. The physician's office nurse reports to the agency and the patient. The physician would like the patient to continue only with the newly prescribed antihypertensive and discontinue the previous medication. How would you respond to 2003? Is this a no? Is it a yes? Or is it a dash? Look at that. Well, we do have at least one person who thinks it's a no. Okay, the correct answer, majority here, are saying that yes. Oh, come on now, move along. The response is yes. There were issues found, the duplicate drug therapy. The issue was identified by the clinician and determined to be clinically significant, because we all know what can happen with those multiple antihypertensives. It required physician contact by the next calendar day, and it met the criteria in 2001 for a potentially clinically significant issue. It was resolved by physician contact, and the actions instructing the patient to stop the old and continue with the new where they were accomplished by midnight of the next calendar day. So yes, there were issues, but all the criteria were met and they were resolved by midnight of the next day. It's alive. Let's try this again. During the assessment visit, the nurse completes a drug review and identifies that the patient is taking both an anticoagulant and a low-dose aspirin. During the visit, the RN calls the physician office and leaves a message with the office staff, providing notification of the potential interaction, requesting clarification of the regimen. The physician does not return the call until after midnight of the next calendar day. How will you respond this time? Was there an issue? Was it resolved? Were all the criteria met? And everyone agrees this time that that was the correct answer is no. And you're all correct. There were issues, but they were not resolved prior to midnight of the next calendar day. That's the reason why you all correctly selected that answer. One more time, and then we're going to take a break, I promise. During the comprehensive assessment visit, the RN identifies that the patient's medication regimen review includes an antihypertensive. His blood pressure today is 136/78. The patient reports that he sometimes feels dizzy when he stands up. So the RN calls the physician office to report this symptom. The physician instructs the nurse to monitor those symptoms for the next 2 days and call if the dizziness continues. The RN makes the 2 additional visits ordered. The symptoms have resolved and the BP remains stable. Consider all the pieces here. Remember all the requirements for each answer. So how will you respond this time? Oh, we have a little mix of opinion here. Some people do think that the correct answer is no. The majority seems to think the correct answer is yes. Oh, clicker doesn't want to behave. There we go. And the correct answer is yes. There were issues found, but even though all the orders could not be completed by midnight of the next day, the RN had completed all the actions possible. And that's the reason why you would be answering yes. Okay. So now we're going to begin looking at 2005, the medication intervention piece. We've talked about medication reconciliation, the drug regimen review, 484.55. I think my life is governed by these numbers. Exactly, right? I see people laughing and nodding. Some of us know the conditions of participation as well as we know our phone numbers. That's sad. The question we're being asked here is, did the agency contact and complete the physician or physician designee prescribed or recommended actions by midnight of the next calendar day, each time potential clinically significant medication issues were identified since the start or resumption of care? We are now looking at a span of time. While I'm thinking of it, before we move into this, I want to answer a question that was posed. Someone submitted it on one of the cards that are on your table, which you can do. The question that was asked was in regards to the time frame and the definition of next calendar day. If your nurse makes the first visit for the start of care or the resumption of care assessment, if they did that today, I've completely forgotten the date, today's the 17th, if they did that on November 17th, midnight of the next calendar day is midnight tomorrow, 11/18. Okay? I believe the concern was if you have 5 days for the assessment for a start of care and 48 hours for resumption, was the next calendar day starting at the end of that period, and the answer is no. We are looking at, here I am today with my patient doing the assessment. I've identified the issue, and based on that, I have to contact the physician and complete the actions as much as they can be completed by midnight tomorrow night, the next calendar day. Okay, I don't know who posed the question, but I hope that that does answer it for you. So let's begin looking at 2005. This is the question we're answering that has to do with the full time period since the start or resumption of care. Let's compare OASIS C1 and OASIS C2, which is what we've done with each of these questions. These are not new, but they are adjusted or altered in the wording. And as I pointed out before, it's these wording changes that are the most critical. As we look at this, I want you to see if you can find where that wording change is and what the importance of it might be. In C1, 2004, it reads, if there were any clinically significant medication issues at the time of or at any time since the previous OASIS assessment, was a physician or physician designee contacted within 1 calendar day to resolve any identified clinically significant, et cetera, et cetera. What are the differences? You should be able to pick up at least 2 immediately. The new wording in C2, did the agency contact and complete physician or physician designee prescribed or recommended actions by midnight of the next calendar day each time potentially clinically significant issues were identified since the start of care or resumption of care? Okay, have you identified all the differences? This is like a word search here. This is how the question used to look on the page with the 3 choices, no, yes, or this does not apply. This is how it looks now. The wording is different, and we're going to identify each of the changes in just a moment. The answer structure is also different. Your choices are no, yes, or number 9, not applicable. There were no potential clinically significant issues identified since start of care, resumption of care, or the patient is not taking any medications. So here are the changes. When you had the 2 questions side by side, did you find all 5? The physician contact and completion of prescribed or recommended actions are required. That's the first one. Each time issues were identified was added. That's a very important phrase, each time. You're going to need to be going back and reviewing these records. Was it resolved within 1 calendar day was changed to by midnight of the next calendar day. Since the previous OASIS was changed to since the start of care or resumption of care. Think about that. That's a difference. If you had episode 1 with a start of care, you did a follow-up OASIS, a research, and 2 weeks later discharged that patient. In OASIS C1, you would have looked at those last 2 weeks. In OASIS C2, you're looking at 10 weeks. You need to go back. This says, since the most recent start of care or resumption of care. And a response is now included here for patients who are not taking any medications. What is the intent? What is the reason behind making these changes? We need to be looking at whether or not potential clinically significant medication issues, such as those adverse drug events, drug reactions, were they identified at the time of or at any time since the start of care and or resumption of care were addressed with the physician or the physician designee. So you do need to be going back through those notes. Hopefully what you're going to find is that the clinician, be it nurse or therapist, whomever is completing the assessment, whomever is the lead on this case, has in fact reacted appropriately with reconciling the medications each time there was an add, delete, or change. And if they identified something, did they respond appropriately by contacting the physician or the physician designee and following the recommended actions? That's critical. How often do you review a chart and find a mention in a clinical note that the patient or a family member contacted the physician and they are now taking such and such a medication, and you realize as little bells go off and the hair on the back of your neck stands up that for the last 3 weeks they've been taking something that's interfering with the action of one of their other medications? Oops. We need to be sure that that's not happening. And this question is going to force us to go back and look and make sure that patient safety is maintained. The caveat is the best practices stated in this item are not necessarily required in the COP. But what did we see on the earlier slide? That your clinicians are following your agency's practice and policy and procedure. So you need to reconcile the two. Best practices, as outlined here, may not be verbatim in the COP. However, the intent is that you follow your agency standard and your agency policy and practice, policy and procedure. So you're going to need to know what those are and what they're going to be. When do we answer this question? 2005. We're going to answer this question when the patient is transferred to an inpatient facility, dies at home, or is discharged from the agency not to an inpatient facility. Because this is an endpoint, and we're looking back from the endpoint to the start or resumption of care, not the most recent OASIS that was done. Here's what the item looks like on the page with your 3 choices. No, number 1, yes, and number 9, not applicable. There were no potential clinically significant medication issues identified since start or resumption of care, or the patient is not taking any medications. Remember, not taking any medications does not mean, no, I'm not going to take them. They were ordered, but I'm not going to take them. That's not what that means. It means there were none ordered. and the patient is not taking any medications. To answer the questions, to enter response number 1, yes. There were issues identified, and the follow-up occurred. The two-way communication and the completion of the actions must have occurred by midnight of the next calendar day, remembering how we clarified that, each time that a potential clinically significant issue was identified since the sock or rock. So you need to take that sentence, parse it apart, and be sure that each of those pieces, each of those segments in here was in fact accomplished in order for you to answer yes. I think we need a battery. There we go. If the physician or physician designee recommends an action that takes longer than the allowed time, then you can answer yes, as long as by midnight of the next day, you have done whatever actions are possible to comply with what you were instructed to do. Remember the previous example. The clinician contacted the physician. Patient was complaining of a symptom from their antihypertensive, of dizziness with position change. The physician instruction was to monitor for 2 days, the first of which was the next calendar day, and to report any continued symptoms. So whatever actions that were possible to comply were done, so that in that previous scenario, the correct answer was yes. And the correct answer here would still be yes. When the issue is identified and the physician or his designee gives you no new orders and simply says, okay, fine, I'm aware, the answer yes is still selected. In your documentation, you would be indicating that the physician or designee was contacted, what the response was, and that this action was completed, because there wasn't anything else you could have, should have, or needed to do. No, we have a problem here. There, whoop. Feisty little thing, isn't it? There we go. When there are multiple clinically significant issues identified, all must have been communicated to the physician or designee with completion of all prescribed actions occurring by midnight of the next calendar day in order to select response number 1, yes. If they were identified either during start or resumption of care, and they were not both communicated and addressed, then you need to say no. You need to have both sides finished in this equation in order to answer the question. Oh, come on, back up. There we go. If the last OASIS assessment completed was the start or resumption of care, a clinically significant medication issue was identified during that visit, the issue was reported both at start or resumption and again at the transfer, death, or discharge, since the time frame that you're looking at is from the start or resumption to the transfer, death, or discharge. That's the time period you need to look at. From the start or resumption all the way through to the transfer, death, or discharge. You need to look at that entire period and look to see if any clinically significant issue that was identified. Was it identified? Was it communicated? Was it responded to within the appropriate time frame? Can you use a dash here? You can. It's a valid response allowed. But the instructions remain the same. You use it if there is no information available or you simply could not assess it. The patient is unexpectedly transferred, discharged, or dies before you can complete the assessment or complete the action. But you do need to complete the transfer discharge assessments as best you can and try to use that dash extremely rarely. You really want to get all the information you can and try to complete the actions in a timely manner. Where are you going to find this information as you're going through and reviewing this entire time period? You're going to be looking in the clinical record, clinical notes, communication notes, what's on the medication list, what's in the plan of care. Can you reconcile all of these together? Have you communicated and had a discussion with other staff who have been assisting you or participating in the drug regimen review in some way? Bearing in mind that the collaboration is permitted, but only one clinician actually scores, enters the answers into the OASIS tool for each of these questions. Okay, who's got the clickers? Let's see them. Clickers, who's got the clickers? Okay, you've got the designated person for the clicker. Our first practice scenario. During that start of care assessment, the nurse completes the drug review and identifies that potential clinically significant issue. On that day of admission, the RN calls and leaves a message with the physician's office related to that issue. Physician does not return her call until after midnight of the next calendar day. No other medication issues arise during the episode, and the patient is discharged from home health care. So how are you going to respond to this question at start of care? Okay, 83% think that it's no issues were found, and 17% think that there were. Think about that now. Think about what we had. You can still change your answer if you want to. And look at that. The correct answer was yes. Issues were found. And were they resolved by midnight of the next calendar day? That's right. I see that head shaking. No, they were not. Okay, let's look at the rationale behind this. First, we want to know, how are you going to answer to 2003? Okay. The first question was whether or not there was an issue found. This one wants to know what you do. Look at your choices, get your clicker there. Okay, we still have a split decision, 2/3, 1/3. And the correct answer is no. And why is that? Okay, I'm hearing a lot more than 1/3 with the correct answers. Okay, now we're going to discharge this person. What is the correct response here? Okay, 3 out of 4 think the correct answer is yes. And the correct answer is no. Okay, what this is telling us is that there's some confusion. Okay, all right, good enough. And I'm having a little trouble with my clicker here. It's not behaving very well. Let's look at the answers, and let's see a show of hands. That'll be a little better. At start of care, 2001. The correct answer is yes, right? Because there were issues found during this review. On discharge at 2003, the physician did not get back to us. And on discharge, that one issue that was found, there was still no resolution. And so we need to be sure that we are answering these correctly. An issue had been identified that was determined by the clinician to be significant. This required physician contact by midnight. So it met the criteria for a potential clinically significant issue, so the answer was yes for 2001. The next one, the clinician initiated the communication, but the two-way communication back from the physician did not occur until after midnight of the next calendar day. Therefore, you have to answer 0 no for both 2003 and 2005. So that's the reasoning. And it does become a little more complex because we need to be able to look at all the components. And all the components need to be answered and need to be met in order for you to say yes at each of these time points. Let's try again. We'll see if I can make my clicker behave a little better. During a discharge assessment visit, the RN reviews the patient's medication list. She confirms that no potential clinically significant issues are present. In reviewing the record, there is documentation that a drug regimen review was conducted earlier in the episode, and no potentially significant medication issues were identified. There is no other documentation to indicate that potentially significant medication issues occurred during the episode of care. So at the time of discharge, the nurse reviews the medications. There are no issues at that time. In reviewing the record, going all the way back, there was an earlier drug regimen review and no issues were identified. And there's no other documentation to indicate that significant medication issues have occurred during that episode. How will you respond to 2005 at discharge? Will you answer no? Will you answer yes? Will you answer not applicable? And the correct answer is C, not applicable. So let's look at the why. Oh, I guess we're not. Let's see, nope. Okay, let's try again. The response, not applicable, is because there were no potential clinically significant issues identified since start or resumption of care. There is documentation. The agency looked for potential clinically significant issues by completing a drug regimen review since the start of care was completed and no issues were found. There were no issues found at start, all the way through the episode, and at discharge. So therefore, there were no issues identified. Yes, the patient is taking medications, but no issues were identified, so this is not applicable. Let's try again. During the start of care comprehensive assessment, this is going to be difficult. You need to be able to meet all three criteria in order for this to work. During the start of care assessment, the RN completing the drug regimen review identified a clinically significant issue. The RN contacted the physician and resolved the issue by midnight of the next calendar day. That was start of care. During the discharge assessment, the nurse reviewing the patient's medication list finds no potentially clinically significant medication issues at discharge. A review of the patient's record, going back to start of care through to discharge, notes that drug regimen review was done during the episode of care, but again, no potential clinically significant medication issues were identified. How are we going to answer 2005 at the time of discharge? Are we going to say no, yes, or not applicable? Bearing in mind how that is defined. Has everybody got an answer in? I still hear a lot of discussion. Let's take a look and see. Oh, that's interesting. We have people who think that the answer should be no. The majority says yes. And a small group say not applicable. And the correct answer is yes. So why is the correct answer yes? During the episode of care, we know that there was one clinically significant medication issue identified by the nurse at the start of care. It was resolved in a timely manner using required two-way communication between the clinician and the physician or physician designee. So yes, something was definitely there. It was reported, it was responded to, and all the actions completed by midnight of the next calendar day. So where does this leave us? 2001, 2003, and 2005 are included in the calculation of a quality measure entitled Drug Regimen Review was conducted with follow-up for identified issues. All three are included in the calculation. This drug regimen review is completed at start of care, resumption of care, to identify these potential or actual clinically significant medication issues. A medication follow-up, 2003, is completed at start of care, resumption of care, in order to determine if any issues identified in 2001 have been addressed with the physician or designee by midnight of the next calendar day. That's the follow-up. The intervention, 2005, is completed at transfer, death, or at home, or discharge to identify if medication issues identified at the time of or any time since start of care, resumption of care, were addressed with the physician or physician designee. So that's a very significant change. You need to look carefully at each of these items and understand the definition. The Drug Regimen Review 2001, that's completed at start and resumption. You're looking at the drug regimen to identify whether or not there were potential or actual clinically significant medication-related issues. 2003 is, again, start and resumption of care. You need to determine if the issues you identified in 2001 were addressed with the physician or physician designee by midnight of that next calendar day. And lastly, 2005 is completed at transfer, death at home, or discharge, so that you have the opportunity to go back and determine whether or not any medication issues identified at start or resumption or any time since, all the way through to the death, discharge, transfer, have been addressed with the physician or physician designee. So remember what the intent and the rationale of each of the separate questions was, and remember what the components are that are involved there. I know it seems very semantic, and it really feels, the first couple times you read and walk through, like somebody just really did stick out a rope 3 inches off the ground to trip you. But this is important, because adverse drug events are a very high patient safety risk. And this is our responsibility. 484.55. This is our responsibility to review the drug regimen, to have agency policy and procedure that governs how we do it, so that we are, in fact, completing the task, complying with the intent, and are answering the question correctly, so that your staff and your agency are getting credit for the quality work that they're doing. So go back and read them carefully to be sure that you do understand exactly what we're talking about. So let's think a little bit. Our time together is getting closer to the end. I know you thought you'd never get rid of me, but I really am going to come down off this stool and go away. But when we do, when our time together is done, what are you going to do when you go back to your agency? Do you have a plan? Have you been thinking about that? How are you going to take this information back? What are you going to do when you're back in your agency? Forget tomorrow. Tomorrow's Friday. You got to recover from all the driving and the traveling and the flying and the hotel food and all those fun things. But Monday, when you start a new week with a big, deep breath, what's your action plan going to look like? You need to take a hard look. What do you have for your existing policies and procedures for things that relate to 2001, the drug regimen review, 2003, the follow-up, and 2005, the interventions? Do you have an existing policy? Do you have a procedure? What backs them up? What does your policy manual look like? When you have policies relating to medication drug regimen review, is there a reference or a resource down at the bottom of the page? What is the policy and the procedure? How do your nurses go about collaborating with the therapist, collaborating with the pharmacist, collaborating with you as a manager? How are they going about doing that to identify where the issues are and to respond appropriately? You need to develop an education plan for all of your clinicians. We must not fall under the assumption that the OASIS assessment tool is for nurses, and that the only time the therapists have any interest is in the functional assessment questions. This tool can be completed by a physical or a speech therapist. So how are you educating all clinicians who need to be able to complete this tool accurately and completely and correctly? That's a really interesting question. What is your education plan? You can use the coding scenarios that are in this presentation. You can develop new ones from your own clinical records and your own experiences. You're the only one who knows. what it's like in your own agency, in your own environment, how you go about dealing with your own physicians that refer to you. What are the ways that you can best accomplish a two-way communication with the physicians and their designees that you deal with on a daily basis? In some areas, in some settings, it may be best to do it through a secure portal email. It might be best to use a fax machine with a cover that says, please sign and indicate whether this is correct or what your plan is. How are you going to accomplish that two-way communication? It's getting to that time of year. Depending on what time frame you use for your annual quality assurance program plan, your QAPI, near and dear to my heart. Well, it really is. Never thought I'd see that day, but I really do. I think it's not only important, but it can be an active living thing in your organization. It doesn't have to be a drudgery and a dusty notebook on the shelf. Okay, I did your clinical record reviews, and there they are over there. And no, I never opened it again, and I never touched it. But it's giving you critical information. This question should be part of your record audits. It should be part of processing every admission, resumption, and discharge. Looking at the drug regimen review, what issues were identified, what did we do about it, was there a two-way communication, and did I get the job done? So make that an active part of your QAPI plan. You're creating 2017. It should at least be in the back of your mind by now. You realize, of course, that New Year's is 6 short weeks away. Hello? We need to have a QAPI plan for 1/1/17. This is an ideal time to think about including reviewing these items in that process. Whoops. Again. There are some resources listed here on the web where you can go to the OASIS Education Coordinators. There's a list. There are some additional tools. You can go to the Home Health Quality Reporting site, look at the questions and the answers that are there. You can call the help desk. You should reach out to any and all of the resources that are available to you. But take the forms that you can use as worksheets to think about developing an action plan to move forward. How will I take this information back to my staff? How am I going to teach this? What are the scenarios that I'm going to use in order to help them to understand and to move forward and do what they need to do? I hope that this has been helpful. This is really considering, there are 5 different changes in the wording between C1 and C2. You need to take them, put them side by side, and perhaps start there as you create your teaching plan so that they understand the differences, can identify those 5 differences, and can move from there with a plan for how they're going to address and document for each of those items. So I'll take some questions. We've reached the end of the fixed material, and the microphones are on each side. Take a second, think about it. What kind of questions do you have? And come up to the microphones. Make sure to identify yourself. I knew you'd be first.
Of course. I came all the way from Alaska. I've got to ask a question.
That's right.
So on...
and we're all proud of you.
2005. So the intent and the question, that word since, start of care and resumption of care. So the intent says, basically you're including what happened during the start of care, resumption of care.
Correct.
The question does not. It just says since.
Mm-hmm.
So I think that's where some of that confusion comes up, and I think it's important to differentiate those. So when it says since, it also means during.
Including.
Right.
Including the start of care.
It's in the intent, but it's not in the actual question.
And I think that you're right. I think you're correct that was the confusion in how people answered it. But you're also correct that in the intent, it does say you need to be including all of it when you code and score the question. That if there was a potentially significant issue on start or resumption of care that was or was not resolved, when you do the discharge review, that does factor into how you answer the question. Okay, are there other questions? Are you seriously going to let me off with only the one? I could get really excited about that. Okay, you have cards on your table. We do have a few extra minutes. If you have the action plan forms on your table, and for those of you who are live streaming, that is available in the folder. If you want to take a few minutes, take a look at that and jot down some notes. Think a little bit about how you're going to actually implement this when you get back home. What are you going to do? How are you going to start? And what are you going to do next?